Hello there guys, welcome back or welcome if you're joining us for the first time. In today's video, we're looking at therapeutic drug monitoring. In short, TDM. All things are poisonous and there is nothing that is harmless. The dose alone decides that something is no poison. Wise word from someone who was almost as great as me, Paracelsus. Alright, so what exactly is therapeutic drug monitoring? It is basically the individualization of drug dosage by maintaining plasma or blood drug concentration within a target therapeutic range or window. From our videos on pharmacogenetics and pharmacovigilance, we've seen that different persons respond to drug differently. There might be a difference in the way their body handles the pharmacokinetics or the way the drug affects them, which is the pharmacodynamics. At the end of the day, this will lead to a difference in clinical effects. Now, this is where TDM comes in. It mitigates this variability by objectively measuring the middle state blood concentration before toxicity comes. So you don't have toxicity or you don't have subtherapeutic effects. So when is TDM really, really important and when is TDM not so important? Well, TDM is very important if the drug has a narrow therapeutic index or therapeutic window and if this drug acts differently in different people. And also, if this drug can have different plasma concentrations, then it is very, very important to do TDM. Another time when it's important is if you suspect that this drug is becoming toxic for your patient or is not giving the adequate therapeutic response, and you're seeing that this patient doesn't really like taking the drug. Maybe if you give the person the drug, once you leave, you choose it away. Then TDM is also very, very important at that point. Another important reason for TDM is if the patient's disease or the drug works in a way that you won't know if this thing is toxic or it's not giving a therapeutic effect until it is too late, then you have to monitor this drug, therapeutic drug monitoring. If none of this is the case, then you don't really need TDM. Another thing to note is that drugs tend to reach their steady state at 4 to 5 half-life. This is important because your average plasma concentration of the drug is the concentration at steady state. So you need the concentration of the drug at steady state to be at the therapeutic window, not at toxic levels or at subtherapeutic levels. When taking a blood sample for TDM, you either take it at the end of a dosing interval, meaning you have to give a new dose, or after you give a new dose, though the default is before you give a new dose. Now, what are some drugs that really, really need TDM? Well, you have antibiotics, antiarrhythmetics, anti-epileptics, immunosuppressants, others like bronchodilators, anti-neoplastics, and antipsychotics. These really, really need TDM. And basically, that is all you need to know about TDM. You can pause the video to see the TDM life cycle blueprints. So, a quick summary. The reason why we're doing TDM is because target regions are done for population studies, and your patient is an individual. Our previous videos know that for individuals have different way of metabolizing drugs or how the drug affect them, leading to different clinical effects. And as a result, TDM is needed for your patients.